A pattern I see in clinic more often than many people realize is an older adult telling me their vision has slowly become blurrier over the past several months, only to assume it is simply part of getting older. They say their reading is harder. Night driving feels different. Bright lights seem harsher than before. Colors do not look quite as sharp. And because the change came gradually, they adapt to it without thinking much of it. I'm Dr. Warren Hung, and on this channel we talk about the hidden health risks that quietly become more important after 55, especially the ones many people miss until real damage has already developed. If that kind of practical, medically grounded explanation is useful to you, consider subscribing. One of the most dangerous assumptions older adults make about vision is believing that every change in eyesight is just aging. Some of it is, but not all of it. Because while aging can affect the eyes, there is another cause of worsening vision that many people never think to question. Sometimes the problem is sitting in the medicine cabinet. A medication can be helping one part of the body while quietly stressing another. And the eyes are more vulnerable to that than many people realize. What makes this especially concerning is that medication-related vision damage often does not happen all at once. It builds slowly. The changes can be subtle at first. A little more blur here. More glare at night there. Slight trouble adjusting from bright light to darkness. Small changes in contrast. Many people compensate without noticing how much their eyesight has shifted. That delay is exactly why these problems get missed. When a side effect appears the same week a medication starts, people tend to connect the dots quickly. But when vision changes develop over months or years, most people do not suspect the prescription they have been taking the entire time. They assume it is age, their glasses need updating, their eyes are tired, or they simply are not sleeping enough. And by the time someone realizes the medication may be contributing, the problem may already be much further along than it should have been. This matters even more after 60 because the eyes become less resilient with age. The lens inside the eye naturally becomes less flexible and less clear over time. That means the same medication side effect that might create only mild symptoms in a younger adult can create far more meaningful problems in an older one. And when vision declines later in life, the consequences reach beyond eyesight itself. Reduced vision raises the risk of falls. It increases driving danger. It makes medication management harder. It reduces independence. And in some cases, if the underlying cause is not caught early enough, part of that damage may not fully reverse. What makes this topic more complicated is that I am not saying medications are bad. Many medications are necessary. Many improve quality of life. Many prevent heart attacks, strokes, dangerous blood pressure spikes, or serious disease progression. The issue is not that medications should be feared. The issue is that every medication involves trade-offs. And one of the most common mistakes I see is people assuming that if a drug is prescribed, it cannot create important long-term effects somewhere else in the body. That is not how medicine works. A prescription being appropriate does not mean it is harmless. It means the expected benefit outweighs the risk when used correctly and monitored appropriately. But that only works if the patient and the clinician are actually aware of the risk. One reason medication-related eye damage gets overlooked is that many side effects affecting vision do not begin with dramatic symptoms. They begin with things people dismiss: dry eyes, slightly blurrier reading vision, more trouble at night, difficulty adjusting to glare, mild haziness, or the sense that glasses never seem quite right anymore. Those symptoms sound minor. They sound like normal aging. But sometimes they are the earliest sign that something deeper is changing in the eye itself. Another reason this gets missed is that older adults often take several medications at once. When someone is on blood pressure medication, cholesterol medication, sleep aids, allergy medication, reflux medication, pain medication, and perhaps something for mood or bladder control, it becomes much harder to identify which drug may be contributing to a problem. People often assume, if one of these were harming me, someone would have told me. But medication side effects are not always immediate, obvious, or severe enough to trigger that conversation automatically. Some require monitoring. Some require the patient to report subtle symptoms early. Some only become concerning after long-term use. And some are uncommon enough that many patients have never even heard the risk mentioned. That is why this conversation matters. Because if you are over 60 and your vision has changed recently, especially if the change has been gradual, unexplained, or harder to correct with glasses alone, it is worth asking whether one of your medications may be playing a role. Not because medications should be stopped casually, and never because you should discontinue a prescription on your own. But because identifying the possibility early can help prevent avoidable damage, the key is understanding that eyesight does not usually decline for no reason. When vision changes, the body is telling you something. Sometimes that message is simple age-related change. Sometimes it is cataracts. Sometimes it is retinal disease. Sometimes it is blood sugar damage. And sometimes it is the medication you never suspected. What matters is not assuming. What matters is asking the right question before subtle damage becomes harder to reverse. But to understand why certain medications can quietly affect vision, you first need to understand how drugs can interfere with the eye in several very different ways, because not all medication-related eye damage happens through the same mechanism. The eye may look simple from the outside, but biologically, it is one of the most delicate organs in the body. It depends on constant lubrication, stable pressure, healthy blood flow, clear internal structures, and extremely sensitive nerve tissue, all working together at the same time. A medication does not need to target the eye directly to affect vision. It only needs to interfere with one part of that system. That is where many people get misled. They assume that if a drug is meant for blood pressure, sleep, allergies, pain, or another unrelated issue, it should not affect their eyesight. But the body does not divide medications into neat compartments. Once a drug enters the bloodstream, its effects can reach many tissues, including the eye. One common pathway is reduced tear production. Your eyes rely on a stable tear film to keep the front surface smooth and clear. When that tear layer becomes thinner or more unstable, vision can become blurry and fluctuate throughout the day, or worsen during reading and screen use. Many medications can dry the eyes by reducing the body's normal secretions. In older adults, this matters more because tear production often declines naturally with age, so the eye has less reserve to begin with. Another pathway is changes in lens clarity. The lens is the transparent structure inside the eye that helps focus light. Certain medications can accelerate clouding of that lens, contributing to cataract formation or making existing cataracts progress more quickly. This does not happen overnight. It can take months or years. That slow timeline is one reason people rarely suspect the medication. Another mechanism involves pressure inside the eye. The eye constantly produces and drains fluid. When that balance is disrupted, pressure can rise. In some people, especially those already predisposed to glaucoma or narrow-angle anatomy, certain medications can worsen pressure problems and threaten the optic nerve. The optic nerve is what carries visual information from the eye to the brain. Once damaged significantly, it does not regenerate well. Blood flow matters too. The retina and optic nerve require a steady supply of oxygen and nutrients. Some medications can alter circulation, blood pressure patterns, or vascular tone in ways that affect how well those tissues are perfused. This becomes more important with age because vascular reserve declines. The same shift in blood flow that a younger person tolerates may create more stress in an older eye. Then there is direct retinal or optic nerve toxicity. Some drugs can accumulate in eye tissues or affect cellular metabolism in ways that gradually injure the retina or optic nerve themselves. These are among the more serious medication-related eye problems because they may progress silently before noticeable symptoms appear. And that brings us to one of the most important misunderstandings patients have. They think side effects should feel obvious. But many eye-related medication effects begin in ways that do not feel dramatic at all. Vision may only seem slightly duller. Reading may become more tiring. Glare may seem harsher at night. Colors may lose some crispness. Or the person may simply feel that something is off, even though they cannot explain it clearly. I remember a patient in his early 70s who kept updating his glasses every year because he felt his vision was getting worse faster than expected. He assumed age was the reason. His optometrist noted changes but did not initially suspect medication. It was only after a fuller medication review that the connection became clearer. The issue was not that the medication was inappropriate. It was that no one had connected his gradual visual decline to the drug's long-term eye effects early enough. And this illustrates something important about how the body works. When a problem develops slowly, the brain adapts to it. People do not compare their current vision to how they saw 3 years ago in a precise way. They adjust gradually. That adaptation can hide decline until the change becomes much more advanced. Another false reassurance many people rely on is this: if the medication were harming my eyes, I would have pain. Not necessarily. Many serious eye problems cause little or no pain early on. Pressure-related damage can develop quietly. Retinal toxicity can begin before central vision noticeably drops. Lens changes can build slowly without discomfort. Dry eye can blur vision long before it causes significant irritation. Pain is not a reliable early warning system for many medication-related eye problems. There is another layer to this for older adults: polypharmacy, meaning multiple medications taken at once. Each individual medication may create only a small effect, but when several drugs with overlapping side effects are combined, the burden can add up. For example, one medication may slightly dry the eyes. Another may slightly affect focusing ability. Another may slightly alter pressure or blood flow. Together, those effects can create meaningful visual symptoms, even if no single drug appears dramatic on its own. That is why medication review becomes more important with age. Not just because of interactions affecting the heart, kidneys, or blood pressure, but because the eyes are also vulnerable to cumulative stress. This does not mean every medication-related vision change is permanent. Some effects improve when the medication is adjusted, reduced, switched, or monitored appropriately. But the reversibility depends heavily on which tissue is affected and how early the issue is caught. Dry eye from medication may improve significantly. Temporary focusing changes may resolve. Pressure-related changes may be manageable if addressed promptly. But retinal or optic nerve damage can be much harder to reverse once established. That is why delayed recognition matters so much. And this is also why I encourage older adults not to dismiss gradual vision changes automatically. If your eyesight has changed, and the explanation has simply been, "You're getting older," that may be true. But it may not be the full story. Especially if the change began after starting a medication, increasing a dose, or spending years on a drug known to affect the eyes. The goal is not to become suspicious of every prescription. The goal is to understand that medications can affect vision through real, measurable biological mechanisms. They can alter tears. They can alter lens clarity. They can alter pressure. They can alter blood flow. They can affect retinal and nerve tissue directly. And because the eye is such a sensitive system, even modest interference can matter more than people expect. But among the many medications that can affect vision, one drug category stands out because millions of older adults take it regularly, often without realizing it carries a meaningful long-term risk to eyesight. The medication category I most often want older adults to understand in this context is long-term corticosteroid use. That includes drugs such as prednisone, methylprednisolone, dexamethasone, and steroid-containing medications used in pills, injections, creams, inhalers, nasal sprays, and even some eye drops depending on dose, duration, and how much of the drug reaches the bloodstream. Many people hear steroid and think only of bodybuilders or athletic performance drugs. That is not what we are talking about here. These are anti-inflammatory medications widely prescribed for conditions such as asthma, arthritis, autoimmune disease, skin disorders, sinus inflammation, allergic reactions, chronic lung disease, and many other problems. Used appropriately, steroids can be extremely helpful. Sometimes they are necessary. Sometimes they are life-changing. But when used repeatedly or for long periods, especially in older adults, they can create meaningful risk to the eyes. One of the best established concerns is cataract formation. A cataract is clouding of the eye's natural lens. As that lens loses clarity, light scatters before reaching the retina. Vision becomes hazier. Colors lose sharpness. Glare worsens, especially at night. Bright headlights can become difficult to tolerate. Age alone increases cataract risk. But steroid exposure can accelerate that process. This relationship has been recognized for decades in ophthalmology and is reflected in routine clinical guidance. Long-term steroid use is a well-known risk factor for certain cataract patterns, particularly posterior subcapsular cataracts, which can affect vision disproportionately even when relatively small. That matters because many patients do not realize their medication may be helping drive the progression. They assume, "My vision is changing because I'm getting older." Age may be part of it, but the medication may be speeding it up. Steroids can also increase the risk of glaucoma, or steroid-induced ocular hypertension, meaning elevated pressure inside the eye. As we discussed earlier, the eye constantly makes fluid and drains fluid. Steroids can interfere with that drainage system in susceptible individuals, causing pressure to build. Pressure itself is not the main problem. The concern is what that pressure does to the optic nerve. The optic nerve is the cable carrying visual information from the eye to the brain. When pressure remains elevated long enough, that nerve can become damaged. Early on, central vision may stay normal while side vision slowly narrows. Because of that, many people do not notice the damage until it is much more advanced. And once optic nerve tissue is lost, it does not regenerate well. That is why glaucoma is taken so seriously. Another problem is that the people most vulnerable often do not know they are vulnerable. Some individuals are steroid responders, meaning their eye pressure rises significantly with steroid exposure, even at standard doses. Others may tolerate steroids with little issue. Without monitoring, you may not know which group you fall into until the effects begin to appear. This is especially relevant if you have a personal history of glaucoma, a family history of glaucoma, diabetes, high myopia, meaning severe nearsightedness, or pre-existing optic nerve vulnerability. Now, an important clarification. Not everyone taking a short steroid course is going to develop eye damage. A 5-day burst of prednisone for an allergic reaction is very different from chronic repeated exposure over months or years. Risk generally rises with higher dose, longer duration, more frequent repeated courses, and cumulative exposure over time. But even inhaled, nasal, topical, or injected steroids can matter depending on the specific product, dose, frequency, and individual susceptibility. That is one reason this issue can be missed. People think, it's only a nasal spray. It's only an inhaler. It's just an occasional steroid shot. It's not like I'm taking steroid pills every day. Yet repeated exposure from multiple forms can still add up. Another overlooked point is that steroid-related vision damage often develops gradually enough that people adapt before they realize anything is wrong. Night driving becomes harder. Reading takes more effort. Headlights bloom more than before. The television looks less sharp. Glasses seem to help less than expected. Many people do not recognize these as warning signs. They simply schedule another vision prescription. That is why medication history matters whenever vision begins changing. Now, I want to be medically responsible here and emphasize something clearly. Do not stop a steroid medication on your own because of this video. Some people need steroids. Stopping abruptly can be dangerous in certain situations. The correct response is not panic. The correct response is awareness and appropriate monitoring. If you use steroids regularly or repeatedly, especially long-term, the smarter question is, should my eyes be monitored because of this medication? That conversation can matter far more than people realize. Because if steroid-related eye effects are caught early, the clinician may be able to adjust the dose, reduce exposure, change the formulation, switch to an alternative medication when appropriate, or begin treatment for pressure-related changes before serious damage develops. But if the connection is missed for years, the opportunity to intervene becomes much smaller. There is another misconception worth correcting. Some patients assume that because they have no eye pain, no sudden vision loss, and no dramatic symptoms, everything must be fine. That is false reassurance. Steroid-related cataracts progress quietly. Pressure-related optic nerve damage can progress quietly. Early glaucoma often causes no obvious symptoms. The absence of pain does not mean the absence of harm. And for older adults, this matters even more, because visual reserve is lower to begin with. If cataracts are already developing naturally, if blood flow is already less robust, if glaucoma risk already exists, then adding a medication-related burden can push the eye from manageable aging into clinically significant decline much sooner. So if you are over 60 and you use steroids regularly, whether pills, inhalers, sprays, injections, or other chronic forms, this does not automatically mean damage is occurring. But it does mean your eyes deserve attention. Because the problem with medication-related eye damage is not only the damage itself. It is how often the damage is discovered after people have spent years assuming the decline was simply normal aging. But knowing the risk is only useful if you know what signs to watch for and what practical steps can help protect your eyesight before subtle damage becomes harder to reverse. Knowing that a medication can affect vision is only useful if you know what to do with that information. And the first thing I want to emphasize is this. The goal is not to make older adults afraid of medication. The goal is to help you catch preventable problems early enough to do something about them. Because when medication-related eye damage is identified early, there is often room to intervene. When it is ignored for too long, some of that opportunity disappears. So if you use steroids regularly or repeatedly, the first practical step is simple. Know whether your exposure is occasional or chronic. A short steroid prescription once in a while is very different from repeated bursts several times per year, long-term daily use, or ongoing exposure through multiple forms such as inhalers, nasal sprays, injections, and oral tablets combined. Many people underestimate how much steroid exposure they actually have because they think only about pills. But from the body's perspective, repeated exposure from several sources can still matter. The second step is, pay attention to subtle vision changes, not just dramatic ones. Many people wait for major symptoms before taking vision problems seriously. That is a mistake. Medication-related eye effects often begin with small changes such as more glare from headlights at night, blurrier reading despite glasses, difficulty adjusting from bright light to dim rooms, colors looking less vivid, a haze or film-like quality to vision, The feeling that your prescription changes more often than it used to. Reduced contrast, especially in low light. Those symptoms may sound mild, but mild symptoms are often when the problem is most treatable. The third step is, make sure your eye doctor knows what medications you are taking. Patients often assume all clinicians automatically share this information. In reality, medication lists are not always perfectly communicated across systems. If your ophthalmologist or optometrist does not know you are on long-term steroids, they may be less likely to connect subtle findings to medication exposure. Bring a current medication list. Include prescriptions, inhalers, nasal sprays, topical medications, injections, and over-the-counter products. Sometimes the missing clue is not what you are taking. It is what you forgot to mention. The fourth step is, ask whether monitoring is appropriate for your level of exposure. Not every steroid user needs aggressive surveillance. But long-term or repeated users may benefit from periodic eye pressure checks, cataract monitoring, or more formal ophthalmologic follow-up, depending on the specific medication, dose, and personal risk factors. This is especially important if you also have diabetes, high blood pressure, glaucoma, family history of glaucoma, prior eye disease, significant nearsightedness, vascular disease. Those conditions can reduce your margin for error. The fifth step is, do not change or stop medication without medical guidance. I want to repeat this because it matters. Many steroid medications are prescribed for legitimate reasons. Stopping them suddenly can create serious problems. Some people require steroids to control asthma, autoimmune disease, inflammatory disorders, or other conditions where poor disease control carries its own risks. The goal is not self-discontinuation. The goal is informed conversation. Sometimes the answer is, continue the medication, but monitor more closely. Sometimes it is, reduce the dose if possible. Sometimes it is, switch to a lower risk alternative. Sometimes it is, accept the risk because the benefit outweighs it. That decision must be individualized. There is no one-size-fits-all answer. The sixth step is, treat unexplained visual decline as a medical issue, not just an inconvenience. Too many older adults normalize worsening vision until it interferes with daily life. They stop driving at night. They avoid unfamiliar roads. They read less. They depend more on others. They change their habits quietly instead of asking why their eyesight is changing. That adaptation can delay diagnosis by months or years. Vision decline is not something to simply tolerate without understanding the cause, especially not when a modifiable factor may be contributing. And there is one more broader lesson here that goes beyond steroids. Medication review should become a routine health habit after 60. Not only for eyesight, for blood pressure, for kidneys, for balance, for cognition, for falls, for fatigue, for circulation, because as the body ages, reserve declines. A medication that was easy to tolerate at 40 may create more meaningful trade-offs at 65 or 75. That does not mean aging makes medications unsafe. It means aging changes the margin for error. So the framework I often recommend is this. Once or twice per year, review your medication list with a clinician and ask 3 questions. First, do I still need each of these? Second, are any of these creating side effects that could be mistaken for aging? Third, are any of these affecting systems I am not actively monitoring, such as my eyes, kidneys, or balance? That simple review can uncover issues many people live with for years unnecessarily. Because one of the most common and costly mistakes in older adult medicine is assuming that new problems are caused by aging when they are actually caused, worsened, or accelerated by treatment side effects. Sometimes the issue is the disease. Sometimes the issue is how the treatment interacts with an aging body. And sometimes it is both. If there is one takeaway I want you to remember from this discussion, it is this. A prescription helping one condition does not automatically mean it is harmless everywhere else. Good medicine is not about pretending treatments have no downside. It is about recognizing risks early, monitoring intelligently, and making informed trade-offs before avoidable damage develops. If your vision has changed and you take steroid medications regularly, even if only intermittently, it may be worth asking whether your medication deserves a closer look. That question alone can sometimes prevent years of overlooked decline. If one of the warning signs in this video sounded familiar, let me know in the comments which one stood out to you most, or what medication topic you'd like me to explain next. And if you find these medically grounded explanations helpful, Subscribe so you do not miss future videos focused on protecting long-term health as the body changes with age. Your eyesight often changes slowly enough that you adapt before you realize how much has been lost. The earlier you ask why something is changing, the more options you usually still have.